appointed dignitaries and delegates, honorable speakers, and esteemed colleagues. A very good morning to one and all. I welcome you all for the second Cardiology Update 2024 organized by Calwin Hospital's Nagercoil. Today, we are gathered here to discuss the latest advancements and challenges in the field of cardiology, exchange knowledge, and explore innovative solutions to improve patient care. This update is particularly important as it brings together some of the brightest minds in our field, providing a unique platform to share and collaborate on groundbreaking treatments that will shape the future of cardiovascular health. I encourage all of you to actively participate in the discussions, ask questions, and share your valuable perspectives. Without further delay, let us begin our scientific sessions. For this session, it is my honor to introduce our esteemed chairpersons, Dr. John Christopher and Dr. Jayseelan, to lead the first session on coronary artery disease. So, Dr. John Christopher, Professor of Medicine in Kanyakumari Government Medical College, Asaripallam. Please join me in welcoming him to the stage. He is an active member of API, IMA, Indian Society of Cardiologists. He has done many research publications in JEBMH and JMSCR. Welcome, sir.
Very good morning to everyone. I am very glad to be here on this occasion. So I thank Dr. Calwin and his team for giving this opportunity to share the first session. So our first session for today's CME program is LPA, its importance and emerging insight and therapeutic. For this, we have an eminent senior cardiologist, Dr. Praveen, MD/DM, is a senior consultant and interventional cardiologist at KIMS Hospital, Trivandrum. His expertise in adult cardiology, interventional cardiology, intervention in adult structural heart disease, imaging in heart and pacemaker device therapy. He has many publications nationally and internationally to his credit. He is an active member of prestigious medical associations like Fellow of Indian Association of Cardiovascular Surgeons, European Society of Cardiology, and Cardiological Society of India. With this introduction, I will call upon Dr. Praveen, Senior Consultant Cardiology, for his talk on LPA, its importance and its therapeutics. Over to you, sir.
Respected Chairperson, senior members, friends and colleagues. So my topic to set the ball rolling is on lipoprotein little a, its emerging insights and therapeutics. So I should confess first that I don't routinely do lipoprotein little a measurement in patients. And I have read lipoprotein little a more voraciously during my MD days than after cardiology. Of course, for this topic I have read a bit. So the significance of lipoprotein little a, basically, when you take the global population, studies have proven that around 20% of the global population have elevated levels of lipoprotein little a. And the importance is that once you have reached a therapeutic target of LDL cholesterol, there is still some amount of residual risk for patients to have further atherosclerotic disease or syndromes down the line. And this residual risk is often attributed to lipoprotein little a. And a correction of this residual risk means that you need to correct the lipoprotein little a in at least some of these patients. And there is ample evidence from data on the role of lipoprotein little a, both in primary prevention as well as the setting of a diagnosed disease or secondary prevention. Now, there are various studies which have proven the association of elevated lipoproteins with aortic valve stenosis, ischemic stroke, MI and heart failure, and there is actually a gradation of risk. More the levels of lipoprotein little a, and that too when appreciably levels are more than 100, there is definitely a higher incidence of these events in patients. And basically, before we go to lipoprotein little a, we should understand that lipoprotein little a is nothing but a modification of a LDL molecule. And we know from our basic biochemistry that lipoproteins like LDL have an ApoB100, And once you add an ApoA, that becomes lipoprotein little a. And so the linkage of apoprotein A to B100 is the most important thing. And if you take an LDL, this is an LDL. So there is basically so much of cholesterol, esters, triglycerides, and there is an ApoB100. And now, when that is, what's happening? Yeah. When that is linked to a apoprotein A by a disulfide bond to the ApoB100, that becomes an lipoprotein little a. So it's an easy structure. And so this ApoA is the one which is implicated in all. So this basically shows the difference between these two in this apoprotein A. And this apoprotein A has basically looped structures called crinkles, and the number of crinkles and its mass basically determines the concentration of lipoprotein little a in blood. Now, there are three basic pathological implications of an elevated lipoprotein little a. One is an atherosclerosis, second is thrombosis. The gene which codes for apoprotein A, that is a similarity to plasminogen, and there is a pro-inflammatory and an oxidative role, and this is very important because the oxidized phospholipids are attached to this one, and that is implicated in deposition even in the aortic valve tissues and even in calcification. Now, various studies have attributed almost a 3 to 4-fold risk of coronary artery disease in patients who have elevated lipoprotein little a. There is also a role in aortic valvular stenosis, especially with calcification. Stroke around 1.6 times the risk, and this risk is irrespective of the LDL levels. So irrespective if somebody has high or low LDL levels, there is a risk from lipoprotein little a. And the basic thing we should understand is that it can be said to be a risk enhancer. Somebody has an elevated lipoprotein, LDL, diabetes, all the risk factors. On top of that, the little a functions like an enhancer of the risk. And so that risk is actually the one which might explain the residual risk in patients who are optimally controlled on statin therapy. And this risk is actually more with higher levels of LDL, lipoprotein little a, especially when the levels are actually above 100. And there is also a secondary prevention role also, because studies are there to prove that there is a relation between the coronary artery calcification score and the levels of lipoprotein little a, and so that can be used as an additive to the coronary artery calcification score in risk prediction in patients. Now, the measurement, what is advocated is, generally lipoprotein little a levels start to rise in infancy, and adult levels are reached usually by 5 years of age. So generally one measurement in lifetime is usually advocated because generally the levels remain stable over time. And the American Heart Association recommendations say that a level more than 50 milligrams per deciliter, or if you take the nanomoles as a value, above 125 is an elevated one. And generally this is also important. You can measure any time. There is no need for a fasting state for the measurement of lipoprotein little a. Various societies have given various levels for lipoprotein little a. Generally accepted one is more than 50 or 125 nanomoles as risk factor for patients who have an intermediate risk of coronary artery disease. Again, the problem is there is a population ethnic variation of lipoprotein little a, so much so that some people advocate that each population's database should be there, and above the 80th percentile of that particular population might be taken as an elevated lipoprotein little a. Now, the relation with aortic valve stenosis, especially higher values of lipoprotein little a have a relation with aortic valve stenosis. There is some data to say that there is a relation with the progression of aortic valve disease and valve calcification. The impact on treatment and all is not yet clear, but there's a field of evolving research. There is also a less stronger association with peripheral occlusive arterial disease as well as with ischemic stroke in patients. Now, this I found very interesting. There is an association actually between lipoprotein little a and calcification, both coronary calcification as well as extra coronary calcification. So much so that many people say that the higher amounts of calcification you see in atherosclerosis might be linked to lipoprotein little a. So this is actually the odds ratio. If you take mitral annular calcification, aortic valve ring calcification, aortic valve calcification and the coronary artery calcification, there is a higher odds ratio with elevated lipoprotein little a. Now, so much has been said about lipoprotein little. What are the factors which basically affect that? This is primarily a genetic one with less role of diet and our lifestyle. And there is more of these levels in blacks and Asians compared with white population. And generally it's unaffected by other diseases except in acute inflammation, acute kidney injury, pregnancy and liver disease, where the levels might fluctuate. And there is some data to say that this has a role in inflammation, because there is some data to prove that this also tracks with the HSCRP levels, and higher these two levels will track with atherosclerosis. Now, so much has been said about lipoprotein little. What is the effect of our drugs on lipoprotein little? Is there any data to show that lowering of lipoprotein little basically leads to protection against atherosclerosis? Statins, there are conflicting effect data on the report of statins on this lipoprotein little, and more than 23,000 patients data have proven that there is no clinically significant effect of lipoprotein little on statins on lipoprotein little. But generally, overall, statin therapy might lead to small increases in lipoprotein little. But then generally you have to take atherosclerosis as a global global risk stratification, and when that comes in, definitely statins have a role in reducing the global risk. Ezetimibe, which is usually given as an add-on therapy for lowering LDLs, they have no effect on lipoprotein little. Again, the newer ones like bempedoic acid has no effect, but niacin can lower lipoprotein little up to 30%. But again, the problem is there is no data on the outcomes or the cardiovascular outcomes to prove that you can recommend niacin for somebody with elevated lipoprotein little. Now, so much of interest in basically lipoprotein little came with the advent of PCSK9 inhibitors, because the PCSK9 inhibitors, they provide the greatest reduction of the available therapies, the greatest reduction little, around 25%. The Fourier trial with evolocumab, they reduced lipoprotein little almost by 26%, and higher the baseline levels of lipoprotein little, the greater is a reduction. The Odyssey trial also showed that on top of high intensity statin, around average 5 milligrams per deciliter reduction is there in lipoprotein little, and that translates almost like more than 20% reduction with reduction in MACE or adverse cardiac events. Then inclisiran, we know that is actually a small interfering RNA. In the Orion 1 trial, reduced lipoprotein little by 25% from the baseline, and the exact mechanism is still not known. But it doesn't alter the inflammation or other parameters of inflammation. But of the available drugs, inclisiran is the one which has shown the maximum reduction in lipoprotein little. Now, but then, if you want to recommend somebody for reduction of lipoprotein little, the most effective one available as of date is lipoprotein epheresis, where you have to remove the lipoprotein little by epheresis, and that's usually done once or twice weekly, and that produces almost a 30% median reduction in lipoprotein little. And lifestyle modification, you tell lifestyle modification for everyone, but routine dietary changes have no effect on lipoprotein little. Some studies have documented maybe some role of saturated fat, DASH diet, but no proven therapy as diet. Again, with exercise, there is no modulation. So basically, we can say that lipoprotein little can be minimally or not affected by diet and exercise as things stand today. The newer drugs, that is where so much of research is going on. 3 possibilities are there in the market. One is antisense oligonucleotide. That's basically synthetic RNAs which that prevents the RNA from synthesizing the protein. Second is small interfering RNA like inclisiran. That basically forms a complex inside the cell and that cleaves the messenger RNA so that the protein formation is not there. And the oral agents which prevent the interaction between ApoA and ApoB100 so that the formation of lipoprotein little is inhibited. Pelacarsen is the molecule which is tried for antisense oligonucleotide that might be expected in the market in a short span. Olpasiran is another one which is also in the clinical trials, and then muvalaplin is an oral one. These 3 drugs are in clinical trials and might be, it's only a matter of time before they are out in the market. So antisense oligonucleotide, what is it? It's an interesting new area where you develop synthetic nucleic acid analogs which basically interact with the Watson-Crick model of mRNA, and they inhibit the synthesis of lipoprotein little. And pelacarsen is that one molecule which has shown more than 80% reduction in the lipoprotein little, a fantastic reduction. Again, small interfering RNA like inclisiran, that basically forms an RNA-induced silencing complex inside the cell, which degrades the protein synthesizing mRNA. Here, olpasiran is a one which is in clinical trials, which produces a fantastic more than 90% reduction in the levels of lipoprotein little a. Muvalaplin is basically inhibits the lipoprotein little a formation by preventing the binding of ApoB100 and ApoA. That is also in clinical trials. So this chart basically shows the reduction of lipoprotein-related drugs. Statins basically increase. Ezetimibe has no effect. Niacin has a reduction. CETP inhibitors out of clinical practice and trials, but still that produces a reduction. Our PCSK9 around 25%. Lipoprotein epheresis, if you do bi-weekly, almost 70% reduction. Inclisiran 26%. You see the pelacarsen, almost 78% reduction. And olpasiran, almost it makes down to null. So such a fantastic reduction is there in lipoprotein little a with these two agents, and this has to be given by subcutaneous injection actually, these two drugs that might be there in the market just like inclisiran in a short while. Now these are the ongoing phase 3 cardiovascular outcome trials with pelacarsen and olpasiran, both Horizon and the Ocean trial sponsored by Novartis and Amgen. So basically these trials, subcutaneous injection once in 4 weeks or once in 12 weeks, and that primary endpoint they do is cardiovascular death, MI or revascularization, and the enrollment is completed and ongoing. You will expect that results to be out in another 2 years. Now, having said so much, as of now, should we measure lipoprotein little a in all? No. We should measure only if you have a family history of premature atherosclerotic cardiovascular disease. You have very high LDL levels where you suspect that the lipoprotein little a is also contributing to the LDL levels, or familial hypercholesterolemia. Many of those labeled as familial hypercholesterolemia based on lipid measurements, you find the lipids are high, you do a genetic study, you don't find familial hypercholesterolemia, you have to check lipoprotein little a because that is mimicking the pattern of familial hypercholesterolemia. Then suppose you give statin to somebody with a very high LDL, high dose statins, still the lipids are not coming down. There you have to measure lipoprotein little a. Then recurrent events, you do PCA, patients on optimal statins, recurrent cardiovascular events, there it makes sense to measure the lipoprotein little a. Then when the levels are high, it is said to be above 50 or above 100 nanomoles per liter. But there is some confusion about the measurement because these assays are only getting standardized. Now, what should you do? Suppose you document that somebody has an atherosclerotic premature disease, lipoprotein little a, what you should be doing? Now, the basic pretext is that it is not a standalone one as of now. You add to the global risk. Somebody has a Framingham risk score of say 7.5%. He or she has an elevated lipoprotein little a. This measurement helps to reclassify this patient to a high risk strategy. And there you might initiate statins to reduce the global risk of atherosclerosis by intensive LDL lowering, and maybe there is some role for inclisiran, but still the data is not very clear. Now, but there is so much lacunae in our routine data on lipoprotein little a that we need more awareness. Even in the best of countries like US, the general awareness even among doctors who test for lipoprotein little a is less. And then testing also, there is so much variability in the standardization of assays. Then again the problem is, even though we say so much about this, the outcome trials are only ongoing, and we need the results of that before we routinely prescribe lipoprotein little a testing to someone. And the standardization, the racial variations we should understand. And again, that the large reductions of lipoprotein little a are needed for benefit. You just reduce by 2 milligram, 3 milligram, that doesn't make sense. You have to have a good reductions of lipoprotein little a to have some absolute benefit in the cardiovascular mortality. Thank you. Outside, I don't know. I'm just talking about my hospital, the hospital where I'm working.
Any questions from the audience?
Once in lifetime of a person,
Yes.
and not do serial monitoring
No.
to see the effect of treatment.
Yeah. So outside of trials, routinely it is even the national lipid guidelines. They don't say for a serial measurement of lipoprotein little a because the levels only change very less over the duration of the patient's lifespan. So much so that you measure once in an adult life, that is enough, unless the patient is part of some ongoing research or clinical trials.
So what kind of patients would you start lipoprotein, and what would you do, I mean, if it's found to be high?
That's what the first thing is. I routinely don't measure lipoprotein little a in any of my patients. Only recently, the executive checkup in our hospital has started to measure lipoprotein little a. We see the results, but then as of now, once you measure, you can reduce the global risk by advising these patients for a high intensity statin therapy. Other than that, you can't routinely recommend any drug to lower the lipoprotein little a.
I think one area where it is coming up is progression of aortic stenosis. Because initially we thought that the risk factors for progression are similar to the risk factors for atherosclerosis. So there had been statin trials. Initially thought it is good, but subsequently it was not found to be useful. Then beyond controlling the risk factors, there is some data to suggest that lipoprotein little a could be an important factor in producing calcification and progression of aortic stenosis. There's nothing else which works in aortic stenosis. In that area, probably addressing this lipoprotein little a could be useful. Because you take all the other things like CAD, PAD, stroke, there are a lot of things you can do to prevent the progression. But aortic stenosis, there's nothing. So this is one area which is probably coming up.
That's what I showed in one slide. There is so much relation between aortic valvular calcification and lipoprotein little a.
You are not used, sir, any experience with niacin, nicotinic acid?
No.
I think nicotinic acid, after the 2 trials, we have stopped prescribing.
Because of
That
side effects.
HPS2 trial and AIM-HIGH trial, in which despite all the lipid modification, there was no reduction in any of the endpoints. So I think nicotinic acid we have not prescribed during the last maybe 15 years, Dr. Mathu?
I have not prescribed nicotinic acid because the statins are so powerful in whatever way you can say that it has been relegated down.
Okay, sir. Thank you very
Thank
much,
you.
sir. Thank
Thank
you
you.
very much for excellent